Hello, this is Karen Cook from the Home Modification Occupational Therapy Alliance, HMOTA, and today we have two very special guests, Scott Trudeau and Sharmila from AOTA. But before we get started, I just want to welcome, I know we've got a lot of new people here today, so I just want to say welcome to HMOTA, the Home Modification Occupational Therapy Alliance, and thank you for coming. There's two goals that HMOTA is really working towards, and that is to promote home mod OTs as leaders in the field of home mods, and also to develop a lucrative business model for home mod OTs. So it's very important that we all work together to promote our profession and also to support AOTA because they do a lot of really important work for all of us. Later on, within the next 2 weeks or so, we're going to have a Medicare biller come in who's going to go through sign up for anybody who needs help still signing up. I will now introduce our guest speakers tonight. We have Scott Trudeau. He's from AOTA, and Scott serves as a productive aging practice manager at AOTA, of course, where he works to advance the role of OT as a primary care provider for older adults. Our other guest we have tonight is Sharmila Sandhu, and Sharmila also works at AOTA, and her specialties are healthcare law, Medicare and Medicaid coverage, and reimbursement. So I'm going to hand this over to you, Scott.
All right. Hi, everyone. Thanks so much for having Sharmila and I join you tonight. We are going to try to give you a little bit of a lay of the land with some of the work that we've been doing at AOTA to support the cause of advancing home modification interventions and OT's role in that through some of the advocacy work that we've been doing with Medicare and some of the work that we've been doing with our own legal counsel to try to get a clear handle on what some of these issues are. I'm going to start the presentation and I'm going to talk a little bit about, since I am the occupational therapist in the team, I'm going to talk a little bit about some of the clinical background and some of the issues related to Medicare and practice. And then Sharma's going to talk a little bit more in detail about some of the specifics of Medicare issues that we see being primary issues when it comes to home modification interventions. So tonight we're going to try to give you a quick overview of some of the Medicare coverage issues, talk a little bit about the legal opinion that we sought, talk about some of the variables in terms of how home modifications are delivered and what that does, and then to talk a little bit about some scenarios. The key issue when we talk about Medicare and home modifications is it's not an easy, there's no easy answers to some of this stuff. It's still quite complicated. I think we're getting a better handle on it, which is making us a little bit more prepared to do some advocacy work, but it's still not as clean as we would like it to be. So just keep that in mind as we're talking. So to set the stage, it's really important to understand that everything that we're talking about is being seen through the eyes of the Medicare guidelines. We're not talking about private insurance paying for home mods. We're not talking about Medicaid. We're not talking about anything but Medicare. So really, really important that you understand that as you hear and interpret some of this discussion. Medicare, in case you aren't clear, Medicare serves folks who are over the age of 65. So for the most part, anyone over 65 is in the US is Medicare eligible, and therefore these rules, I'm air quoting since you can't see me, these rules apply to folks that we're serving who are over the age of 65. And one of the key things, and Sharma is going to talk more about that in a few minutes. Yes, Sue Doyle said, and some people with chronic disabilities and with end-stage renal disease also qualify for Medicare before they're age 65. But the vast, vast majority of folks who are Medicare eligible and who are served by Medicare are over 65. And one of the key issues when we talk about Medicare, which Sharma's going to talk more about as we proceed, is that OTs cannot waive Medicare billing requirements. So we cannot opt out of billing Medicare for services that could be eligible for Medicare reimbursement. So we'll talk a little bit more detail about that as we go. So what am I talking about when I say that we sought legal opinion? We, as you all know, many of you have contacted Sharmila or I in the past and asked questions, and we have done our best to try to support and answer those questions. But it got to a point where we did feel like we really needed some outside eyes to look at the issues and to make sure that our interpretations of what we saw in the regulations was consistent with what other people were seeing. So we sought and paid for a legal opinion, which actually took probably close to 6 months of work to get through, to answer the question, is home modification interventions by an occupational therapist, are home modification interventions by an occupational therapist reimbursable by Medicare? And if so, under what conditions? And if not, under what conditions? And in response to that, the attorney actually set course on trying to figure some of this stuff out. And we tried to guide her, but not sway her opinion, if you know what I mean, because we were paying her for her opinion. We didn't want it to be our opinion just through her eyes. So one of the things that I took away from that whole process, which was very interesting, when we started and she started looking at the Medicare regulations, she came back and said, well, Medicare is a healthcare provider. Home modifications are not healthcare. Ergo, I don't know why you're even asking me this question. And so we really started from square one with her, trying to help her to understand what occupational therapy is, why environmental modification and environment matters in terms of people's functional status, and how that then translates into health status and well-being. And so through that work, we got to the fourth bullet with her, which is that she confirmed through her legal eye that in fact home mods are part of the scope of occupational therapy practice, and that is across almost all states. So again, just to reiterate, the important fact is that Medicare pays for health insurance, and they do not pay for home modifications, right? Because home modifications aren't healthcare. But no, that's not true, because within the scope of occupational therapy practice, as we treat people to improve their function, part of our mechanism for doing that is through the environmental modifications that we can provide. So you're beginning to already maybe get a taste for some of the complexities that we're dealing with when we're talking about this. But I do also think I want to underscore one point, which is that Medicare provides health insurance. And the reason why I'm underscoring that is because you may be aware that to some extent, some of those definitions of health are being challenged and are evolving at this point when we start talking about things like social determinants of health. And certainly within the realm of social determinants of health, home is a key factor to supporting health. So I tried to work up this schemata, and I'm not sure if it's effective or not. It's the first time I'm sharing it, so you all can give me some feedback of what you think of it. But I wanted to show, again, in a sort of simple representation, why there's some complexity to these issues. Because not everyone who seeks our services for, so this slide tries to show that depending on the status of the individual that's coming for service, it's going to impact how much or how close they are to requiring Medicare billing. And the idea here is that, again, Medicare is a healthcare provider, so anybody who's in a acute or post-acute healthcare setting is probably, and gets referred for home mods, is probably going to require some manner of Medicare billing. On the other side of the continuum are folks who may be a well elder who are being proactive or who have decided that they're going to modify their bathroom and update the fixtures, but in doing so, they want to get the input of somebody to support them to age in place as they proceed through the aging process. So those folks, that type of service for prevention is not considered health care by Medicare and therefore would not be reimbursable by Medicare. And then the other scenario on that side is when folks contract with a builder and do their work without doing the traditional evaluation and plan of care of an occupational therapist. And there's some folks that work in that model.
Can I just interrupt you for a second? So
Sure.
that an OT is working with a builder, then we don't have to bill Medicare?
If the OT is contracting, and you'll see it, I'll show you a scenario in a minute. We'll explain that. We'll explain that one a little bit further in a minute. Because you're right, you're picking up on the nuance, right, Karen, that it really depends on how involved you are with the actual client, the individual with a disability, and what the referral source or what the healthcare status of that individual is. So we'll talk a little bit more about that. So in scenario one, so the question is, there are no scenarios where prevention is paid for by Medicare, ? And the answer to that, to the best of, and Sharmila, feel free to weigh in, but the answer to that, to the best of my understanding, is that's true. Medicare does not pay for preventive services. Medicare pays for health care. So scenario one, a patient is discharged home post-stroke hospitalization. Home health agency deploys the OT to the home. There's an environmental and home safety evaluation completed as part of the OT eval. The plan of care reflects the need for DME and training and other minor home modifications. What do you think? Is OT required to bill Medicare? The answer is yes.
Yeah.
Hopefully that was an easy one. So again, it's very easy in this situation to see that the medical referral, the plan of care reflects the modifications. So it's a traditional transaction between the occupational therapist engaging with the client, doing an evaluation, developing a plan of care, which reflects the modifications and the training and the follow-up that those modifications are going to receive. That would be billable through Medicare, through traditional Medicare. In scenario two, this is the contractor one that Karen was asking about before. The occupational therapist consults to a builder on altering the home of an 82-year-old individual with left hemiparesis post-stroke 9 months ago. The builder shares information about the needs of the consumer. The OT provides information and engages in active problem solving with the builder. What do you think? Does that require Medicare?
This one is no engagement with the client at all, right, from the therapist?
Correct.
Yeah, so this one would not be a Medicare.
That is correct. So the tricky part to this, right, some of the nuances to this is that the person did actually have a stroke. So there is some medical reason, perhaps, why they need alterations to the home. However, because, but he could benefit from OT, Sue says, she added, especially if there are changes made. And then, see, the thing that gets dropped, I think, when this contractor transaction happens, is that the follow-up and the work that we do in once the alterations are made, getting people to use them effectively and to build them into their routine and habit system is really what gets lost. So OT could be helpful, you're right. But in this scenario, it's okay for the OT. So who pays the OT in this scenario? What do you think?
I would guess in this scenario, the builder would pay the OT, but I think but let me just kind of give you a little more depth on what I as an OT do with a builder. Typically, so I have a construction company. So somebody will call my construction company and say, hey, we need a home evaluation at this house. So we need to put together a plan for the home modifications. So I'll go over and I'll meet with the clients. I'll check into their ADLs, their functional mobility skills. We'll evaluate the house, and put together some beginning designs. And then that's when the builder comes in. So what about that scenario?
So this is a really good example, I think, of the gray, because the first couple of steps that you described, where you go in and you look at the functional status and you do an evaluation, that piece then is something that, under the right conditions, could be reimbursable by Medicare.
Even if it's 9 months post?
So again, so what happens in this situation is that because that service in some situations could be billed, you would be asked to have the person sign an ABN up front, which we're going to talk more about. That's an advanced beneficiary notice. We'll talk more about that in a minute. Have that person sign that up front, and then do the billing, get the rejection, and then that person can private pay. Now, somebody posted there was a flurry of comments, and I'm trying to keep track of them, but somebody posted, you could just bill privately, but have the patient private pay. And the issue with that is not really okay according to Medicare regulations. Going back to what we said earlier, people who are over 65, who are Medicare eligible, occupational therapists cannot waive their responsibility to bill Medicare. The issue is that, and it's important, I keep having to remind myself of this, so that's why I'm bringing it up, that rule is not in place to make our job more difficult or more complicated, or to say that our work is not valuable. That law is in place to protect the older consumer from being scammed.
So Scott, what if this particular consumer got out of the hospital and had a home health OT do a home evaluation right after they got out of the hospital, and then here we come 9 months later and we're doing a home evaluation that's much more complex than what you're allowed to do in home health. So usually they take about 3 hours, or 2 or 3 hours depending on what the payer is, but either way. So even though they already had a home evaluation by an OT that's already been reimbursed for Medicare 9 months ago, if we're going to do it again, we need to bill Medicare for that?
So the scenario is, it's not whether or not you bill Medicare as much as, well, it is whether or not you bill Medicare, but when you're going into that scenario as you described it, right, you're not really expecting Medicare to pay you. You're expecting the client to pay you, which is why you're going to get an ABN up front. But you are going to bill Medicare, and you're going to have them deny that so that you then are authorized to take private pay.
So Scott, I'm going to come back to a couple of questions because I face this all the time. In fact, I'm getting called by case managers where home health has done an assessment, but it hasn't met the client's needs. They've been discharged from home health, and they call me back in and say, this client has fall risk in the bathroom. I've had no problems going back in and billing Medicare and getting reimbursed because it's a safety risk. The need hasn't been met. The therapy that they had prior did not solve the situation. And under Medicare, the falls prevention and the home safety part of MIPS and everything else, that puts that really clearly in the domain that's reimbursed. And the physician and the case managers are very clearly on that side in terms of signing off for medical necessity.
And that's a very different scenario, right, than this one with the contractor.
Yes, absolutely.
Yes. So when you have a case manager or you have a primary care physician who has made an assessment or a determination that there needs to be further assessment around safety, that would be completely billable, and Medicare would likely pay under Med B. So again, these are the nuances and the picayune details that make this rather complicated, right? It is in fact complicated.
Hey, Scott, would you prefer people put things in the chat or just speak up and ask you questions?
Oh, have I missed questions in the chat? I've been trying to keep track, but if I don't really have a problem either way. I'm happy to interact. The problem is if people are turning on their mics and turning off their mics, we may end up with a lot of back reverb again. So that could be a problem. I want people to hold this sort of unsettled feeling that they're feeling right now. I want to turn the mic over to Sharmila and have her continue to describe what I started to describe with the ABN. And then we're going to have plenty of time at the end for some follow-up questions and thoughts. So hold on to this, see if some of the additional information helps you to get a handle on what you're worrying about or what you're thinking about. And then we'll try to come back and see where we stand after we get through, okay? So without further ado, here is Sharmila Sandhu. Sharmila, are you on mute?
Oh, she must be.
Hey Scott, this is Clarice real quick. I just want to clarify for some people who are talking about that home health is limited time or that they are limited to certain evals or certain modifications that they can do. I just want to make sure that people understand there's a difference between what is typically done in home health versus what Medicare allows under home health. Medicare has placed no restriction on the amount of time you can spend in a home health eval under Medicare Part A. So if you wanted to do a 3-hour home modification eval in home health Part A, you certainly can. It's usually the agency that's placing that limit. So, and Medicare doesn't really take into consideration what the agency is placing a limit on. So there's a difference between what Medicare does and doesn't cover versus what an agency will and will not allow, if that makes sense.
Yeah, that makes perfect sense.
Thank you, Clarice, for clarifying that.
Sharmila, are you still with us? Or did you...
This is Julie, and I want to clarify that also. It seems like Medicare doesn't put a specific recommendation on how long you spend, but they also don't just reimburse for 3 hours.
Well, they don't reimburse for individual occupational therapy visits anyways. It's now a bundled payment.
Right.
Under Part
So the
B, they
agency
actually charge.
So you need to work it out that there are no other disciplines needed and that the reimbursement that the agency is getting can all go to a 3-hour evaluation and follow-up.
Right, which would be more of an agency problem than what Medicare does or doesn't cover. So that's why
Right,
it would still...
I appreciate that. But go into it knowing what the agency is dealing with in terms of what their reimbursement is, and then work it out with them, because it's not that many clients that need it, and on an individual basis, you might be able to negotiate with your agency that that's all they need.
Yeah,
absolutely. Or that they need that in addition and cut back on the nursing or something.
And I think part of the discrepancy is that some of us are talking about Part B and some of us are talking about Part A. So if you're in the home health agency, you may be billing under Part A. And so the reimbursement structures are slightly different than if you're billing out on Part B. Clarice, do you want to go further on that, or is that enough?
No, yeah, I think, because I mean, under Medicare Part A, you're billing as a traditional home health agency, and obviously occupational therapy is not a qualifying service. So you'd have to have other disciplines involved before you could do that evaluation. Under Medicare Part B in the home, that's definitely something where if you did a 3-hour evaluation, more likely than not, a good chunk of that is going to be treatment. So you can bill both the evaluation and the individual codes for the treatment session. So whether that be self-care, therapeutic activity, whatever you feel it best fits under. So that'd be an opportunity to actually get reimbursed for the amount of time that you're present in that session versus your Medicare Part A. That's an untimed code essentially because you're not getting reimbursed for CPT codes.
And now that we can do OASIS, are we still considered, whatever that wording was you just mentioned, that we can't be the only one in there?
Yes, so it's a qualifying service is what it's called. So it still stands that PT, speech, and nursing are still the only qualifying services. Occupational therapy is not, and it's only under the state of emergency that we've been approved to complete the OASIS start of, or to initiate, excuse me, an OASIS start of care. So once the state of emergency is over, it's anticipated that we will go back to the old regulations. Although, even though we're hoping that our advocacy efforts will prevail and get a permanent solution.
Thank you for that.
Yeah, and it's not clear what's going to happen with that process. So I wouldn't change too many of my protocols just yet until we have a better sense of what's happening. So Sharmila is trying to get on. I'm going to try to send her the phone number, so hold on for a second. I will.
Sharmila, do you have chat? If you have the chat, I can help you with that. I assume she must not have that either, though. Oh, you're on the chat? But you need the phone number so you can get it to you first, Scatter Eye.
She said when she's coming off of mute that there's been an issue.
Oh. Actually, I'm afraid to mess with this, otherwise it may close out everybody.
Sorry about that. So I'm back.
Were you able to get her the phone number?
Yeah, I sent
maybe
her the
somebody
phone
can.
number.
maybe somebody can call her and she can be on a phone call, a conference call by phone.
She can call in to this number actually and then be on the same platform we're on.
Yeah, that would be the ideal.
Let me get that for her.
So I just sent her the 571-317-3122 number with 601-630-853 as the meeting number.
Good. She should be able to get in with that.
Caller 8, is that Sharmila?
Okay, can you hear me?
Oh,
There
yay.
you are, yay.
Oh my goodness. I am very sorry. I got kicked off at some point and then couldn't seem to get the audio. First of all, thank you, and I apologize for that. I heard up until Clarice began talking, and I think I have a gist of what she said. Hopefully I didn't miss too much, and I will just start out with this slide, and then we can go from there. I did want to just say that all of your questions are extremely on point from the ones that I heard up until about 10 minutes ago, and I really think you're asking the right questions, and I understand how complicated this is. What Scott said, and that the wonderful introduction he gave, is all very accurate, that if you kind of back up to thinking about the Medicare program as being very, very protective of the populations that it serves, both the elderly over 65, the disabled and NESRD population, there is an attempt to sort of, whether we like it or not, at all costs protect those more vulnerable patients from any potential issues with payment and or fraud and abuse issues. And so that is some of the history to the Medicare program that really lends itself to these issues. One of the things that I've talked to a number of you about over the years is this concept of opt-out. In spite of that protectiveness that the Medicare program has, and I am a lawyer by training as well, and have worked at a law firm for about 4 years, and then moved into policy and policy advocacy with a number of different organizations and associations over the past many years. I recognize that opt-out has created an opportunity for physicians and certain other health professionals that allows them to request private payment or private billing of Medicare beneficiaries. And unfortunately, occupational therapists are not within that group of the Social Security Act that are permitted to opt out at this time. I'm going to get to another slide later, which shows you some bright spots and opportunities I see within federal legislation, within our federal advocacy team, to push back against that. But right now, this is the current status of where we are. And so I just wanted to share with you the section of the Social Security Act that speaks to that, as well as the current status. And Scott, we can move to the next slide. Can you guys still hear me? Okay, great. Can you guys still hear me?
Yeah.
Making sure. Okay. Thank you. As Scott said, I wanted to talk a little bit about just the billing facts and considerations as you're asking these really good questions about various scenarios. In our article that we published in January that kind of walked through a few scenarios, it was challenging because we wanted to provide you with a very clear Medicare coverage scenario where you really need to go back to the Medicare coverage rules. And again, as Scott said, this was really about Medicare being one of the largest payers and a lot of the patients that you see. But it might be a different analysis under a private or commercial payer, and it's a different analysis potentially even under Medicaid, as state programs vary pretty significantly. But for Medicare, it goes back to looking at what they cover in those key things that they want to see. They want to see a plan of care that at some point is physician certified, even if not immediately when you create that plan of care and those goals for the patient. Medicare kind of requires this process that you're doing a functional evaluation, and then you're really working with that client longer term to create goals and carry out a plan of care in order to kind of move them forward in the areas that you see necessary. And there's also the piece of it being skilled. It must be viewed as medically necessary and a skilled intervention. And those were some of the things that this profession, I think, fought for in historically in order to get Medicare to recognize occupational therapy as a health profession. So really, though, if you kind of go through that analysis of, did you do an evaluation, did that involve an assessment, and we're going to talk about that in the next slide. What all of those questions that you're going to need to ask yourself ultimately result in is your clinical judgment and making a determination of whether under the Medicare program, are these medically necessary services or not? And that, unfortunately, a lot of that responsibility falls back upon the clinician and you all to make that determination, to think through these various considerations. So we can move to the next slide.
So Sharmila, thank you. Before I do that, we had a question that I think is worth probably addressing sooner than later, which is if we can't opt out as providers, can our patients opt out and decide that they want a private pay and not bill through Medicare? Do they have that ability?
They do, and that process, though, is required through a form that's called the Advanced Medicare Beneficiary Notice of Non-Coverage, which I'm going to talk about within a few slides, and that's the process that Scott referred to just earlier in the presentation. So let me get there and we can talk about that form in detail. So these are some of the questions to ask yourself when you're treating a patient that is Medicare covered. They fit the criteria that we talked about, and they're Medicare enrolled, and that's their primary insurance. You want to ask, is there a certified plan of care, physician certified? Are you doing an evaluation using a functional assessment? Are you providing in-person skilled therapy interventions to the client? And I also think that in-person piece is very important. Are you meeting with the client? And is this part of a larger analysis that may lead to the development of a plan of care? And we did note that the home safety assessment is a skilled Medicare covered intervention. And so I think that's important as you think through kind of what that looks like. That is something that pretty certainly needs to be billed to the Medicare program, that intervention in and of itself. And then we can look at those other interventions that might come along after that. We've heard of scenarios where that home safety assessment might be done and might be billed in Medicare, but then there's additional work of doing something like tearing down a wall or restructuring the home. And those services may be clearly non-covered, but those services then are going to require that, in some cases, those services might require an ABN. We can move on to the next slide. So the Advanced Beneficiary Notice of Non-Coverage is sort of, I think, in a lot of ways, this is the magic bullet to understand. We talked about a lot of the scenarios, but I really, really encourage you to pull up this form, look at it, and then also read the instructions. There's a separate link in our article that we published in January that links to the instructions for this form. And to be totally frank, they're kind of complicated, and it might even be a separate webinar in and of itself to talk about the different ways to complete the ABN. But this must be provided you Medicare beneficiary when you'd like to charge privately for your services. It must be signed prior to the service being rendered with the appropriate billing option selected within the form. And Scott, if you want to move to the next slide. So many of these services are covered on maybe services that would be potentially covered under certain circumstances, but they're not payable because in your circumstance, they're not considered to be medically necessary services. So if there's a reason you believe the treatment of that Medicare beneficiary for a particular date is not reasonable and necessary and not Medicare covered, the beneficiary has to sign the form, and it has to be prior to providing those services. This notice is the form that's used when those services would be denied for lack of medical necessity, and using this form is mandatory in those circumstances. There's also another set of circumstances where the ABN can be used for non-covered services and it's voluntary. So the builder scenario that Scott walked through earlier is really a voluntary case. It's where you aren't providing those very clear plan of care, you have a plan of care, you're kind of providing all of those required skilled services that Medicare covers. You don't actually have to provide the form. You can complete it to protect yourself and submit it, but in that very clear case, it doesn't need to be. It's in the gray cases that we talked about earlier that we do recommend using this form. We don't recommend, though, using it in a blanket way, so that where you have your client fill out an ABN without a date specified or a service specified and keeping it on file sort of as a, just in case something happens. That actually is something that CMS and OIG has addressed as not being appropriate and being a potential problem. So when you go through these options on this slide, there are 3 options that you can choose from. And if you choose this option 2, you're indicating, the patient is actually reading that and indicating they do not want you to bill Medicare and that you should not bill Medicare. And they're making it, that decision is to be made by the client themselves, with the practitioner explaining each of the 3 options, but without undue influence or without pre-checking that box. You really kind of have to walk through those options per the instructions for this form. Something that I wanted to be able to point out to you. So there's their most recent form is in the link to the article that I shared with you, and really do encourage you to look at this, because I think reading these instructions and looking at this form is really going to help with understanding when it has to be used and when it may not have to be used. Scott, I think we can move on. And just very quickly, I wanted to move back into the concept of opt-out. One of the, glimmers of hope that I have and our federal affairs team and regulatory affairs team has about opt-out for occupational therapy is this paragraph in this slide was included in the 2020 President Trump's budget for Health and Human Services this year. And you'll note that it actually specifically talks about revisiting non-physician practitioners who do not wish to enroll in the Medicare program and may opt out for 2 years, and kind of give some detail, and specifically mentioned occupational therapists in their paragraph for EG. And I think we kind of feel like a lot of that is due to the fact that we have been advocating to be included as a profession that can opt out for several years now. One of those opportunities was with a regulatory comment period called the red flag rules that looks at the opportunity to do paperwork reduction, which has been one of this administration's key priorities. And another point was with a congressional comment period, I believe, to Ways and Means, that was looking at various legislative opportunities. So this would require an act of Congress. It would require federal legislation to get done. But there have been pre-COVID, pre-coronavirus, we saw some movement and some opportunities, and I'm very hopeful that we will see some opportunities again. So I wanted to just point that out. We can move. And then I think that now we can kind of try and take your questions. These next few slides provide resources to you, because I'm sure during the current epidemic and public health emergency, we've created a bunch of different documents. This first one is up from our coronavirus webpage. Scott, if you want to move on to the next slide, these are actual federal agency resources, CDC, OSHA, just so that you have them available. And I think that's it. So opportunity for questions. I don't have access to the chat box, Scott, so I don't know if you want to read any of those questions.
And that was our first managed space program.
Well, luckily that was our first manned space program. So apparently there's a couple questions in terms of opt-out and speech and PT. Can they opt out, Sharmila?
No, they're in the exact same situation as us. as therapy professionals. We fall into a category, all three therapy groups as allied health, that do not have the ability to opt out, but it also has been an opportunity for collaboration. In particular,
Right.
physical therapy would very much like to be able to opt out, and we've been working with them closely.
Great. Can you put up the prior slide with the email addresses? Yes. We got that one. So do we have the patient POA? Let's see. Do we have the patient or the power of attorney sign the ABN form when they are being discharged from OT services?
That's a
So the
very
whole
good
key
question.
Well, the key to the ABN, right, is that it's advanced. So it's before the services take place.
Correct. And, you know, optimally, if the patient is cognitively or physically able to understand and sign, you would want that. But if there is, in fact, a power of attorney in place to assist and support the patient, my understanding is that is completely acceptable.
That's a legitimate use of the power of attorney, sure.
Yeah.
Were there questions in the chat box that we haven't addressed? I've been trying to keep up with them, but maybe missed a couple.
I just want to
What was
make
the
a
question?
comment, Scott, about that question
Sure.
that says, do we sign the ABN form for a client being discharged from OT services? So there's no need to sign the ABN if they're being discharged unless you're continuing to provide a service that's not a Medicare covered service. For example, you're doing a wellness program, an exercise program, or something like that.
Right, so they're being discharged from a more traditional occupational therapy role to something that's more preventative, perhaps. Then you could do an ABN to cover yourself for providing that. But again, the key to the advanced beneficiary notification is that the patient or the client is notified before services are delivered about what their options are. So if it's preventative services, that's certainly the time before the services start. So if they're being discharged and then starting a different program. But if they're being discharged, the horse has left the barn and you shouldn't really be needing an ABN because it's too late.
Right. So if they're being discharged, I'm a little unclear from another occupational therapy plan of care, is what I'm hearing, and that's completed, and you're initiating new services, you would do sort of your analysis about, is this a Medicare covered service that we walk through? And if you are clear that it's not, then you, you know, or you want the patient to be able to sign that ABN to be safe, you could initiate it. But the discharging of services, if I'm understanding correctly, should not require that.
So Monica's asking for a clear distinction between of wellness for preventative home safety eval. So the way I think of it is, again, it's initiated usually by the consumer that the person is being proactive. They're not being reactive to a healthcare need. They're being proactive. They're thinking about the future. And in order to support their wellness going forward into the future, they have initiated a request for some support and some assistance from an occupational therapist to do a home eval. That's the way I think about it. But other people may think about it differently.
So Scott, question, what if it's, say, someone who has a progressive disease like rheumatoid arthritis? They're over the age, you know, they're Medicare age, and you get called in to go to their home and, take a look around, see what's going on with them, see what's going on with the house, and then consult on designs.
Consult with
this
whom?
is Sharmila. Might I, Scott, just interject for a moment that exactly who's calling you in? I think it's important, even though, Scott and I have kind of turned this over. Is there an order by a physician or a nurse practitioner, PA, for those services? I think that's an important component, because traditionally Medicare will want to cover the services when their doctor, their primary care, their neurologist is recommending occupational therapy. So that's one key piece. Is it a family member that wants you to look at their home?
I will just add, to go back to what Sue Boyle had said earlier, that the idea that someone with chronic rheumatoid arthritis, right, may actually fit into the scenario she gave earlier, where even if there's not an acute exacerbation today or this week, but the primary care doctor sees that there's a safety risk to that person continuing, and they reach out and they initiate an OT eval, then that in fact would not be the traditional wellness kind of intervention, right? So again, it's really complicated. And maybe this is my shortcut, but I always start with just what Sharmila just did. Where is that referral coming from? How is that person showing up on my doorstep? And why? And then that starts to give me some indication about the direction I might be going in.
So here's my other take on that. Because of the MIPS, there's such an emphasis with the doctors for home safety evals and the CDC requirements and the MIPS requirements. OT home safety eval is clearly spelled out in there. I often then advise clients that this service can be covered, and there's not a question about that, because often with my clients, the money to pay upfront privately versus being able to then pay for some of the modifications, which in most cases there's not an option to get covered anyway, gives them more money. The other piece with that is the clients have a little bit more trust. I found if, it's like I go to them and say, here's how this could be covered, but is it illegal then for me to go back to the doctor and say, because this is what I have been doing, is go to the doctor's office and saying, I was contacted by the case manager, I was contacted by the family, this person is having a series of falls, here's what I can offer. Is this something you're agreeable for a referral that may be medically necessary under these conditions?
So the
I
question
That's what I do too.
I personally don't see a conflict with that. I mean, the other thing that sometimes I think you could potentially do is to, again, ask depending on the status of the individual or their family, to ask them to go back to the primary care doc and get the order for the eval. Those kinds of things happen all the time. And we communicate back with the other members of the health team to get the services that people need when they need them. So I don't see that as being any kind of a conflict.
This is Sharmila. I agree with that entirely. It's almost more of a discussion among the health consult or discussion among the health professionals about that individual. I don't see an inducement or an attempt to increase either your or the physician referrals under that. So that seems completely reasonable to have that discussion. And then if that physician chooses or whomever chooses to order OT or refer to OT, then you can start those services.
We have a good question, which will get the whole group thinking, I think. So an age-friendly community initiative group is using grant money to have me go in and provide aging-in-place evaluations. Some of these seniors are in fine health and some are not. In this situation, since it's preventative, it is fine to use the grant money, ? Even if the senior has some real physical issues.
I think you should get more money from the grant, save the money from the grant and use Medicare as much as you can, and it will make the grant funders more likely to use you in the future.
Ooh. So
we actually believe the opposite of that. That it actually is a better if we can get paid under the grant services, that would be helpful, and under preventative services, therefore not Medicare.
Right. So that was really the key. That was really the key to what I read was the term preventative. That so there's no, and Sharmila, correct me if I'm speaking out of turn, but there should be no obligation to bill Medicare for services that are preventative in nature, that are funded. It's not like you're billing the client for those services. They're funded services. The patient's eligible for them. By all means, you should take advantage of the grant money to provide them with whatever resources you can.
So my question.
Well, at least keep the data of what could have been billed to Medicare, because you've got that much more data for the next time you're looking for a grant.
So again, if in fact, this is where it's tricky, right? If in fact it is preventative, though, none of it would be billable to Medicare.
Correct, but what I found is there's a backlog of this happening in the community. So some of it definitely under these grants have been preventative, but some of it has definitely been going in where there's a major fall safety risk happening right now. And so their screening criteria under some of those hasn't always been that the client's preventative, just because these services have not been offered before.
I rarely find a preventative situation that isn't, I don't really feel it, how do I say this, but I wouldn't feel right not billing it under Medicare. I mean, unless you're asking me for what's the most beautiful grab bar, almost everything I do has a major safety factor of fall prevention and increased function.
Did I lose audio?
You're there.
No, I can hear you.
Okay. So right there, and again, this is really where the clinical judgment piece that Sharmila was talking about earlier, that the judgment has to be about, is this preventative or is this so again, safety is safety, but what is medical safety? What is medically necessary in terms of safety? Ideal may be different than safe. And so again, if you're going in and you're presenting resources through a grant, I think that I like the person who said keep track of what might be billable. I think that that's an interesting sort of thing to track, but I don't think that from this discussion, it really is important to worry about. You're not doing anything wrong by going ahead and using the grant funds to support that initiative. Now, again, the grant will run out, so then you have to figure out at some point what your next steps are going to be.
Because I think the bottom line, this is Clarice, in terms of protecting the client, like that's why these things are all in place, is to protect the patient from fraud or from being abused and misused. So if you aren't charging the patient for services, you are only providing them a benefit. You aren't trying to charge them more money than they might have to originally pay, right? Because if it's covered under Medicare, then ideally they'd either only have some sort of, either not have to pay anything or just have to pay a fee depending on how it's being billed. But So that's the whole goal of these ABNs and having to go through Medicare. But if you're providing a service for free or through grant money, then you're not really running as much of a risk of defrauding the patient by charging them something that they wouldn't have to pay for otherwise, if that makes sense.
So you were doing so good, Clarice, until you said if you provide it for free or through grant money. So again, so Medicare gets a little tricky, and the rules and laws get tricky when something has real value, but we offer it for free, because then the system thinks, uh-oh, something's gone awry here. There's some problem here. Somebody's at risk. So giving stuff for free is actually different than using grant funds to do it. So just be careful about that. Partnering with Rebuilding Together, well, they have a budget, they have funds, they have resources. That's like using grant money. But you going out of the goodness of your heart and offering things for free to maybe get the word out about your business, or to use that as a marketing strategy, that could come back to bite you. So be careful about that. There's a question about discussing a scenario where the adult children want the OT to assess mom and dad's house because they've experienced multiple falls and fractures, and there's some mild cognitive issues. So here's my take on this. This could go any number of different ways. If, in fact, the adult child is going to pay for the services as a gift to their parent, then, and you are going to contract with the adult child, there's a possibility that you could not have to bill Medicare. Now,
I thought Sharmila said if it's not like a medical professional contracting with us, that it would not have to be Medicare billable. She said it depends on who's asking us.
Right. So I said the same thing. So
Right.
I said, if the adult child initiates it and they're going to pay for it, then you don't have to bill Medicare. You can avoid billing Medicare. Now, if the adult child reaches out to you, makes you aware of this train wreck situation, which you then feel, you need to, again, to go back to Sue's earlier comment about case management and home safety, and you need to get the primary care doctor involved, and you need to get resources to this couple in addition to evaluating the home, then you're going to be in a situation where that's going to turn, and you're going to have to think about billing Medicare. So again, you see the nuances. The same case, or what on surface looks like the same case in three different sets of circumstances, could require a different course of clinical action and billing.
So Scott, let me make sure I understand this. So if an adult child, or say somebody's husband or the client themselves, call us in and say, hey, I've got rheumatoid arthritis, I need to do something with my house. Since they were calling us in and it's just there amongst us, and then possibly we'll bring in a builder later, but then since there's no physician involvement at this time, it's just the family and the OT, then we don't have to bill Medicare.
No, I don't think it's that clear. I think you have to use your clinical judgment to evaluate whether or not the services could be billed through Medicare. And if you believe they could be, then you're going to be going through the hoops to do that process, whether it be, getting an ABN because you're not sure that Medicare will cover it, or going full blown and as we said before, getting the primary care doctor involved and getting the referral and going through the process of doing the OT eval and billing Medicare.
So ask us, we have to find a physician and get an order, but we're not allowed to open our own case. But what did Sharmila say? Sharmila said something about it depends on who it comes from, who the request comes from. What did she mean by that?
So can you guys hear me?
Yeah.
Okay. So I think in your example, so that let's say an adult daughter contacts you, they are concerned about an existing condition. They want you to come in and do maybe a home safety evaluation, look at the design of the house. I think then you've got to say, go in and you and maybe you don't go in, but you get information. Do you need to do a functional assessment, which is a covered involves, a covered evaluation? Do you need to establish a plan of care with goals? So are you doing that sort of traditional OT plan of care? I think it really is, it's incumbent on each therapist to determine because those are Medicare covered services, and then that triggers having to bill CMS. If you're not doing those sort of traditional plan of care, evaluation, and then intervention activities, even then, some of those services you might still say, oh, I'm not sure, but I don't think they'd be covered. We would recommend you make the patient sign an ABN to protect yourself. But unless it's so crystal clear, which was the builder example, right, that this doesn't even involve the patient or your meeting with that patient, to assess them in any way. So it's sort of it's this analysis that kind of falls back upon the professional to walk through. Does that make sense?
So let me just clarify something. I don't know if I've been doing this since 2006. I've never worked with a builder where I didn't evaluate the client myself and not just have him tell me what was going on. So I don't know if that's a relevant scenario, but so for instance, someone with rheumatoid arthritis, I'm just sticking with the rheumatoid arthritis here, calls me in. I do look at what their function is, what their mobility is, take a look at the house. But I don't write goals for them. I would write up short-term modification recommendations, like adaptive equipment recommendations or grab bar or something simple, but also long-term modification recommendations like redesigning the house and doing design work. What of that is Medicare billable that I would need to worry about?
So Scott, jump in, but my sense is that when you said you evaluate or assess the patient, so then the determination becomes, is that medically necessary, that Medicare would cover that evaluation, or is it more preventative? Is it something where it's hard, this is a gray. Maybe they haven't had an acute episode in the last 2 years. They're just doing their functional, if you aren't necessarily needed to kind of treat them, you're doing this more for the purpose of redesigning their home. That is exactly the gray area here that requires sort of your kind of thinking through. But if it's for, you notice major functional issues that then you think requires more intervention with that patient on working on ADLs or other issues, that then becomes a Medicare billable. Those services become billable.
But if I'm not providing any of those other services, then it's not billable.
So it's not whether you're providing it, it's whether the clinical scenario would require it. And so I think that's where it gets a little tricky too. Because I think that, we hear all the time, well, I'm not a Medicare provider, so I can't bill Medicare, so I don't bill Medicare. And it's like, well, then you're not necessarily practicing under the rules and regulations because you can't opt out of billing Medicare. So those kinds of scenarios, it's not it's really the underlying clinical presentation. If the patient could benefit from those services, whether you're providing them or not, then that should be a Medicare
Webinar.
billable service.
This is for pickup. That's the ice cream and cookies. Yes, pickles. There's a gallon of milk and up here fridge.
Thank you. I appreciate that. I thank you so much for explaining that.
Okay. And that's why in some ways we hate this, because somebody asked a question online. I can't remember who it was and how far back it was, but is there a distinction? Does AOTA recognize a distinction between folks who have post sort of advanced certification or some kind of advanced practice in home modifications? And the short answer is yes, but what does that mean exactly? There's no clear definitions of what that means. And in terms of Medicare billing, remember you said at the beginning, we're just talking about Medicare billing. In terms of Medicare, they don't necessarily make that distinction, right? So yes, we understand that what they will pay for is different, but if you're doing the evaluation, even if you're going to go in, and Sharmila and I have talked about this, even if you're going to go in later and do, a massive reno and tear down walls and you're going to be involved at that level because you're an advanced practice OT in the area of environmental modifications, that's fabulous. But maybe that initial evaluation that you're doing is still billable under Medicare. And maybe that portion of your work should still be billed to Medicare. And to think about that, Sue made the point that Medicare pays, that she gets paid by Medicare. It's not such a big deal, and that maybe it's not at the highest rate available, but consistent money is good money. And so thinking about that, and I'm not sure why there seems to be an aversion to billing Medicare. I think we need to think about that too, because again, when you think about it from the healthcare and from the consumer perspective, the Medicare rules and regulations are set to support both of those, healthcare and the consumer. So,
Scott and Sharmila, I'd like to bring up one more thing that would come in here related to this about billing, and we've had this discussion before, and also at some of your presentations at AOTA with Sharmila. One of the things is like the eval rate is around $127 for an eval. That's not what I bill for doing the home assessment, and I know you brought that up as about it being an intervention. But I wanted to just have the discussion about, for the eval, I do a functional assessment, I do a COPM, and then the walk through the house and looking at the environmental impact on all those ADLs, I bill as treatment, because that's looking at making recommendations, looking at education, all of those pieces. What are the thoughts about that process?
So it's a very good question. So there isn't currently a CPT code, a code that has been valued to do I don't believe the work that you do, specifically doing home safety evaluations. The general OT evaluation, and right now we have a low complexity, moderate complexity, and high complexity, 3 different levels that Medicare will pay. So arguably, one might say that it could fall under moderate or high, right? But the actual way that those general evals were valued in the AMA coding process was not based on looking at these specifics that you do. So one of the things in terms of advocacy that we've talked about is, do we need a new code? do we need to go to AMA and request the development of a new home modification code for this work in order to get the value? And is that can that be differentiated from a general evaluation? And that's a question that I think is still out there. I would, offline, I would love feedback, but that's something that could be done in order to really capture the cost that the general evaluation, overall evaluation, does not cover. I don't know, Scott, if you have more to add.
No, I think that's really helpful. And I think that, again, we share the frustration, and we are trying to move. Please understand that we are trying to move the needle closer to support the work that's actually happening. And the other piece that concerns us greatly, and me personally as an OT, is that we do not want the most qualified people to do this work to be pushed out of the marketplace because of cumbersome paperwork and ridiculous regulations. So that's the other piece that we're desperately trying to advocate for. And that's why the optimism about the potential for us. So again, if I were somebody with an advanced practice in home modifications and the ability to opt out of Medicare, I would be on the same footing as any other builder or whatever in my marketplace to go out and to sell those services. So that's something that we're advocating for. That would be our goal, is to get that to happen.
Mm-hmm. I absolutely want to underscore that. Thinking about this, and really, as Scott said, diving deep on these legal issues for almost 6 months, this last year, I don't think the health systems, the payers, just don't contemplate this level of innovation. That's how I personally feel, that this is something that's sort of forward thinking as the elderly population continues to age into older years, and all of these issues. It's a sort of a necessary service. We do see legislation coming around aging in place, and I think that there's lots of opportunity to get these types of services covered by payers, but it's a process. And that's kind of the way we've been. We've been focused on opt-out, but on the other hand, we've been focused on trying to get Medicare and other payers to recognize the value of these types of services that really look at social determinants of health, social risk, the types of things Scott was talking about. So that's in the future, but I know it doesn't solve your problems today.
And there is a potential that, the other sort of light at the end of the tunnel is, because this notion of social determinants of health are being looked at more carefully, there's also the potential that other resources within our social structure may be looking at supporting some of these things. So, maybe home modifications is not best situated in the Medicare reimbursement or healthcare reimbursement world. Maybe that should be covered in another pocket of funding through HUD or through something else. So there's all sorts of potentials, but I do think that we are in fact moving in the right direction, and I hope that you'll keep working with us to advance that cause. Thank you very much for your time.
Thank you.
Excuse me, I have a question.
Thank you very much.
I have a question now about this, the current situation we're all in with this coronavirus. And there's a bit more talk about the importance of home and how can we benefit from some of that view instead of not so medical, but just that, well, everybody's at home now, but how is home's been designed and how can we make it better in the future?
Yeah, I think you're right that the current crisis is actually, bringing up a lot of what's the word I want? It's really showing a light on some of the issues that have been present in our quote unquote system, that now are going to need to be addressed. I mean, I've heard everything. I had a conversation a week ago with folks at the Administration for Community Living because they're concerned that more seniors are falling in the doorway because they're getting meals delivered, but instead of getting their one meal from Meals on Wheels, they're getting 7 days worth of frozen meals, and they're putting them in a big box and they're leaving them on their doorstep, and they have to get out to the stoop to get the meals in, and it's a heavy box. And so it's exposing these weaknesses in our system, and part of that is the housing stock, and part of that, is the fact that we are going to need to think carefully about, how do we support if folks are going to live in place and age in the community, then we really need to have available supports and resources beyond just home modifications, but certainly part of that is retrofitting homes to meet the needs of the population. So I do think, yes, I think, right now at the height of the crisis, I don't think people have their most creative thinking caps on, but I do think that there's going to be a whole lot of work to do to review what worked and what didn't work during this crisis, and hopefully we can advance the cause and make some further improvements in the system.
Thank you so much. Yeah, I think and I really hope one big thing that I feel like we've been fighting for quite some time is just to make sure that we got a seat at the table for all these discussions. And I'm glad that we've got you over at AOTA, pushing so that OT will be included with the monies that they are, whether it's on a community basis or like with the Capable program, or if it's through the Medicare billing, that they do refer to home mod OTs as a necessary part of making homes accessible.
Yeah, I agree. I think the next couple of years are going to be pretty interesting ones.
Absolutely.
Please, and Sharmila, please, anything you need from us, or if you could keep us updated as far as what's going on and anything we can do to support what you're doing, we all need to work together on this.
Absolutely, and as you know, we're interested in keeping a closer relationship going with you all at HMOTA. So hopefully we can continue in the next year to make that happen and to sort that out further.
Perfect.
Yeah, so we'd be happy to do that.
Wonderful. Thank you so much, both of you, for spending your time and coming here and meeting with us and talking with us. Please know you are always welcome anytime you want to come and speak with us. We're anxious to speak with you and to support AOTA.